I'm Dr. Robert Jones, and this is the Focus First Trimester Ultrasound Lecture. At the completion of this lecture, the learner should be able to describe the sonographic findings of the normal first trimester pregnancy, describe the sonographic findings of the abnormal intrauterine pregnancy, describe sonographic findings of hemoperitoneum, discuss clinical applications of the focused exam, and discuss exam pearls and pitfalls. The focus question we're going to be trying to answer here is, does this patient have an intrauterine pregnancy? So we're going to be concentrating on the findings within the uterus here, both transabdominal and transvaginal. We're not going to be spending time on how to evaluate the adnexus, since this requires a greater degree of skill, and it's not realistic that someone who has had a 1-hour lecture and has done only several hands-on first trimester exams that they would be able to accurately evaluate the adnexus. So we're going to be sticking with the findings within the uterus. It's important to remember when performing the focused first trimester exam that it's not a fishing expedition. We're going in there to answer that specific question. Does the patient have an intrauterine pregnancy? Remember, you want to choose your patients wisely when performing this exam and really ask yourself, do the sonographic findings of an IUP explain the patient's symptoms, and does it allow you to safely discharge them home? A benign-looking patient with spotting who has an intrauterine pregnancy, no free fluid, and you have no concern for any other intra-abdominal pathology can be discharged home. Somebody who comes in complaining of severe lower abdominal pain, even if you were able to diagnose an IUP with a focused exam, you still haven't explained why the patient is having such severe pain. So keep that in mind when performing this exam and any other focused ultrasound exam. Let's look now at the sonographic anatomy of the female pelvis. Looking at the uterus first, it's a muscular, here's the myometrium, hollow organ. It's going to be located posterior to the urinary bladder and anterior to the rectosigmoid colon. And it's going to be composed of 3 layers. You're going to have the endometrial layer, the myometrial layer, and the serosal layer. The only 2 layers that you're going to be able to visualize with ultrasound will be the myometrial and the endometrial layers. Here you have the posterior cul-de-sac. This is the most dependent portion of the female pelvis, and this is where fluid is going to initially accumulate. Larger amounts may move along the back of the uterine fundus and may go into the anterior cul-de-sac. In some patients, depending on how they were positioned prior to the scan, you may only find fluid in the anterior cul-de-sac, so don't forget to look in this region when assessing the patient for free fluid. In terms of uterine size, the normal non-gravid uterus is going to be about 7 to 8 centimeters in length. It is going to be about 4 to 5 centimeters in width and about 4 centimeters in AP thickness. Looking at uterine developmental variants, there are 2 that you need to know. One is going to be a bicornuate uterus, and that's where you're going to have 2 uterine bodies or horns and 1 vagina/cervix. And here you can see that there are 2 uterine bodies here, so this would be the right and this would be the left horn, as compared to a didelphia uterus where you have 2 uterine bodies. You would also have 2 cervices and 2 vaginas. Let's now look at the transabdominal pelvic exam. The exam should be performed with the patient in the supine position. In terms of transducers, I would recommend using a large footprint 2 to 5 megahertz curvilinear. Something in the range of 2 to 5 megahertz will allow adequate penetration in the average size adult. You could use a small footprint curvilinear transducer or a phased array transducer, but I think it's easier to use a large footprinted transducer for this exam. In terms of patient preparation, a full urinary bladder is going to be ideal, but the exam should still be attempted even if the patient is just voided. And this is usually the case in the ED where patients are asked to give urine specimens when they are triaged. Performing the exam, you want to make sure that you scan through the entire uterus. This is essential. Let's first look at the transabdominal sagittal exam. So this exam is going to be performed with the transducer in a sagittal plane with the indicator directed towards the patient's head. The transducer should be placed just cephalad to the pubic symphysis, and this will give you this image: anterior, posterior, head, foot. Here you've got urinary bladder in the near field. You can see some reverberation artifact here, which is common. Here you can see the uterus here, which is anteverted. You can see the myometrium here, and you can see the hyperechoic endometrium here. This is going to be the posterior cul-de-sac, and this is going to wrap around here into the anterior cul-de-sac here. Down here you've got the cervix, and here you can see the vaginal stripe. Here's an example of a transabdominal sagittal exam where we sweep from side to side, surveying the entire uterus. So you can see we're sweeping from one side of the uterus to the other. And again, you can see here on this uterus, the uterus is anteverted here. You've got urinary bladder. Here's vaginal stripe. These are Nabothian cysts here. This is going to be the cul-de-sac here. You can see bowel adjacent to the uterus here, but if there was free fluid, you would see it here. You can see the myometrium here, and you can see the hyperechoic endometrium. Here we have a patient with a retroverted uterus. You can see here as we sweep, anterior, posterior, head and foot. Here's urinary bladder. Here's going to be vaginal canal into cervix, now going into the uterus. You can see the myometrium here. You can see here is a sac within the uterine fundal region, but you can see that the uterus is tipped back posteriorly. So this is a retroverted uterus, and the cul-de-sac is back in here. On the transverse exam, you're going to take the transducer and you're going to place the indicator towards the patient's right. Again, you're going to be just cephalad to the pubic symphysis. This is going to provide you the following image: anterior, posterior, patient's right, patient's left. Here's urinary bladder. Here's a short axis view of the uterus, and cul-de-sac will be back here. Here we've got a transverse exam here. You can see that the transducer is going to be angled in a caudal and then cephalad direction, sweeping from the cervical region all the way up to the uterine fundus. This way you are able to fully assess the uterus. Here we have the transverse sweep in the patient with the retroverted uterus. Again, it's going to be the same thing. You're going to angle the transducer so that you're able to fully evaluate from the fundal region all the way down to the cervix. Now let's look at the endovaginal exam. To perform the endovaginal exam, you want to make sure that the patient is in the lithotomy position. This is going to allow you to move the handle of the endovaginal transducer up and down. If you've got the patient flat on a cart, you're going to be limited in your ability to perform the exam. The exam is going to be performed with the endocavitary transducer. Preparation of the transducer will include placing gel on the footprint of the transducer, covering that with a sheath, and then placing Surgilube over the sheath. In terms of patient preparation, ideally the patient's urinary bladder should be empty. When you insert the transducer, you want to make sure you start watching the screen the minute you insert the transducer, and you're going to start looking for landmarks. The first thing that you may see when you go in is going to be the urinary bladder. You're going to next attempt to find the cervix in the lower uterine segment, which you're seeing right here. You would then need to adjust your depth as needed. You can see here is cervix and lower uterine segment. Here you've got the uterine fundus. You can see some of the endometrial stripe here. And you can see once the lower uterine segment is recognized, you're able to then go from side to side, as well as angle the transducer up and down in order to bring the uterus into the central part of the screen. Don't perform this exam the same way that you perform a vaginal speculum exam. If you insert the probe too deeply here, you're not going to be able to fully visualize the uterus, particularly one that's anteverted or one that is retroverted. So once the endocavitary probe passes the introitus, watch the ultrasound screen as you slowly insert the transducer. Based on your pelvic exam and or transabdominal exam, you should have an idea as to whether or not the uterus is tilted from one side or the other, and this may also be helpful information. But here you can see that if you insert the transducer in too far, you're going to limit your visualization. And if we think about fixes for a vaginal speculum exam when we can't see the cervix, we tend to put this speculum in further into the posterior cul-de-sac, hoping to get the cervix to drop in. If we use that same type of a logic here when doing the endocavitary exam, we're going to actually be counterproductive. We're going to end up with limited visualization, and we're going to cause the patient discomfort. On the endovaginal sagittal exam, you're going to end up with the following orientation. Here you've got the transducer in the vaginal canal, so this is caudal direction. Here you're going to have the cephalad direction because you're aiming the beam up towards the patient's head, with the indicator at the 12 o'clock position, meaning your thumb is pointed up to the ceiling. This is going to be anterior. This is going to be posterior. Here you get a nice view of this anteverted uterus. Here you've got the medium level echogenicity of the myometrium. Here you've got the central endometrial cavity here. Here you've got the posterior cul-de-sac, and here you've got the anterior cul-de-sac. Now you can see that you get much better resolution here with the endovaginal exam as opposed to the transabdominal exam. However, these exams should not be used in exclusion of each other. They should be used together. I always recommend, regardless of how early you think the patient is, start off with the transabdominal exam. Since you're using a lower frequency transducer, you're going to get a broader view of the pelvic anatomy. It's possible with this high frequency coned in image here that you could miss pathology. So remember, don't use the one exam in exclusion of the other. Start with the transabdominal exam. If that gives you your answer, you can stop at that point. If you don't have your answer, then move on to the endovaginal exam. Remember, scan the whole uterus. So here we've got an anteverted uterus here. This is caudal, cephalad, anterior, posterior. Here you've got myometrium. Here you've got endometrium. Here's the posterior cul-de-sac here. What you're going to do is you're going to take the transducer and you're going to sweep from side to side. In the sagittal plane, by bringing the transducer towards the patient's left thigh, you're going to visualize the right side of the uterus. By bringing the transducer towards the patient's right thigh, you're going to visualize the left side of the uterus. But it's important, just like on the transabdominal, that you scan the entire uterus. In addition to sweeping from side to side on the sagittal exam, you're going to bring the handle up, and by doing that in an anteverted uterus, you're going to get a better look at the lower uterine segment and cervical region, as well as the posterior cul-de-sac. So you've got caudal, cephalad, anterior, posterior. If you want to visualize the uterine fundus better in a patient with an anteverted uterus on the sagittal exam, you drop the handle down, and that will give you this view. Here's caudal, cephalad, anterior, posterior. You're seeing some urinary bladder here, but here you've got a nice view of the uterine fundus. Here's the myometrium, and here is the endometrium. Let's take a look at these two patients. On the left here, you've got a patient with a retroverted uterus. Here's caudal, cephalad, anterior, posterior. Here you've got the lower uterine segment here, and you've got, as you follow the endometrial cavity back, you can see that it is going in a posterior direction, so this is a retroverted uterus. Here you've got caudal, cephalad, anterior, posterior, and you can see following the endometrial stripe up to the fundus here, it's in an anterior direction, so this is an anteverted uterus. The endovaginal transverse or coronal exam is going to be performed by taking the transducer indicator and going from the 12 o'clock position where your thumb would be pointed up at the ceiling to the 9 o'clock position where you have the indicator directed towards the patient's right thigh. And that's going to provide you with the following image. The transducer's in the vaginal canal, so this is caudal. The transducer is shooting the beam up towards the patient's head, so this is going to be cephalad. This is patient's right, and this is patient's left. Here you have a short axis view of the uterus. You've got the surrounding myometrium, and here you can see the centrally located endometrium. When we look at the endovaginal transverse exam, again, you're going to have to sweep in order to evaluate the uterus in its entirety. So when you're in the transverse plane with the indicator towards the 9 o'clock position or the patient's right thigh, you're going to end up bringing the handle up and then down in order to fully interrogate the uterus. You can see in a patient with an anteverted uterus, by bringing the handle down, you're going to evaluate the uterine fundus. And by bringing the handle up, you're going to be shooting the beam more posteriorly, and you'll be going into the lower uterine and cervical region. So again, make sure when you perform this exam that you do a full sweep going from the cervical region all the way through the fundus. Let's now look at the normal intrauterine pregnancy. Sonographic evaluation will begin at about the 4th week when the intradecidual sac can be first visualized. It's important to recognize, however, that until you see a yolk sac or an embryo, you cannot definitively diagnose an intrauterine pregnancy. Just like in real estate, it's all about location, location, location. If you look here, you've got your myometrium, your endometrium, and then your endometrial stripe. Think of this much like you would this cul-de-sac here. When you're building a home, you're not going to put the home in the middle of the road. Think of the endometrial stripe as being the road here, and think of the endometrial area here as being the yards. And you can see here, this is where the homes are built, that there's some border between the road here, and there's also going to be a border here looking at these as being the backyard here at the endometrial myometrial border. So remember, it's important to assess where the pregnancy is implanted. And here you can see endometrial stripe, that's the road. Here's the endometrium. Here's where the houses are. They're not out here in the myometrium. They're not very close to the edge here. And you'll see in a little bit as to why that's important. But really take a look at where the pregnancy is implanted, because that's a key thing to understand and to look for. Okay, so again, intradecidual sac. Here you've got this sonolucency here within the endometrium. Could it be an early IUP? Possibly. It's definitely the first sonographic finding of pregnancy, but it's not diagnostic of an early IUP. So anything before this approximate 4-week period of pregnancy, you're going to have a normal pelvic ultrasound. This is going to be the first thing that you see, but again, until there's a yolk sac or an embryo in there, you can't definitively call this an IUP, because there are other things that may look sonographically like an intradecidual sac, but they're not. Here's a transverse view here of an intradecidual sac, and what you can see here is there is, within the endometrium here, you can see here's the endometrial stripe, and it gets deformed a little bit here. So this is the intradecidual sac. It's implanted eccentrically within the endometrium. You know, much like we had talked about earlier, it's not dead center in the endometrial stripe or the road. It's off to the side. The house is in the yard. Here we've got a closer look. Here you can see the endometrial stripe here. Here's the endometrium, and this is the myometrium here and here. So as we kind of sweep through, again you can see endometrial stripe, it's bowed a little bit here. You've got a decidual reaction, and here you've got this intradecidual sac. Here we have a patient transvaginal sagittal exam. So this is a retroverted uterus because the fundus is back here. It's caudal, cephalad, anterior, posterior. Here you see this sonolucency or sac-like structure here. So is this automatically an intradecidual sac? It's in an unusual location. There's no surrounding decidual reaction. You definitely can't call it an intrauterine pregnancy because there's no yolk sac or embryo within it. But as we sweep through on this patient, you can see here we have an intrauterine pregnancy here within the endometrium. This is where you would expect it to be. And this one's actually a definite IUP because there is a yolk sac within it. What you were looking at earlier, this sac-like structure in the lower uterine or cervical region, is an Nabothian cyst. So there are other things that can look like an intradecidual sac. When you see what you suspect is an intradecidual sac, you can take measurements of it to obtain a mean sac diameter. This has been found to be accurate to within 5 to 7 days menstrual age. However, it's important to understand you can do mean sac diameter measurements of a Nabothian cyst, of a decidual cyst, or any other structure that you want. So just because somebody tells you, I measured a sac and it's 5 weeks, 5 days, does not mean that it's definitively an IUP. Briefly mention here the double decidual sac sign. This was first coined by Nyberg back in the 80s, and this was before transvaginal scanning was routine. And because there was a longer window before you would end up seeing the yolk sac or the embryo just via the transabdominal window. Remember, if you don't see a yolk sac or embryo and you just see a sac-like structure, you can't definitively call it an IUP. So clinicians and researchers looked for ways to better understand the appearance of the intradecidual sac and to see if there were ways that you could definitively call it an IUP before the presence of a yolk sac. And Nyberg felt that this was a highly sensitive finding, that if you saw a double decidual layer around that sac, that went along with an early IUP. Since that time, there have been several small case series where people have shown pseudosacs of ectopics that appear to have a double decidual sac sign. So the bottom line here is it can help you to favor the diagnosis of an early IUP if you see the double decidual sac sign. But again, it's not 100%, and you still have to wait until you see the yolk sac or the embryo. Yolk sac, which you see here, it looks like a little Cheerio within the gestational sac, is the first definitive sonographic finding of an IUP. You're usually going to see this at about 5 to 5.5 weeks menstrual age and at about a quant of 5,000. It should have an echogenic ring and an anechoic center, and its inner wall to inner wall diameter should be less than about 5.6 millimeters. Here we have a transvaginal exam, sagittal and coronal windows in a patient with an anteverted uterus, and you can see here is the decidual reaction, the gestational sac, and there is the yolk sac within the gestational sac, and you can see it in two planes here. So this is a definitive early IUP. The presence of a calcified yolk sac, like you see here, is associated with pregnancy failure. It's not the cause of the pregnancy failure, but it's the result of the pregnancy failure here. And you can see on this transverse transabdominal sweep here that you've got this calcified yolk sac here. Here you have an embryo, and we'll talk about embryos in a little bit, but this embryo is greater than 5 millimeters and there's no cardiac activity, so this was a patient who had pregnancy failure. Here we've got a patient who also had a pregnancy failure and was in the process of miscarrying. On the sagittal exam here, you can see this is an anteverted uterus here. We're down by the lower uterine segment here, and you can see that the patient has a heterogeneous decidual reaction here. The sac has an irregular shape to it, which is not what you would like to see. Here you've got an enlarged yolk sac. It is echogenic with a central clearing, but a yolk sac that's greater than about 5.6 to 5.9 millimeters is associated with aneuploidy. If you look here, you can see another ring here, and this is the amnion right here. And here we've got a transverse view. There's yolk sac, and you can see some of the amnion here. So this was a patient who had pregnancy failure. The fact that the yolk sac is enlarged would lead you towards the possibility that the patient had aneuploidy. Let's now look at the embryo. You're usually going to see this by about 6 to 6.5 weeks menstrual age and a quant of about 13 to 15,000. If you have a crown rump length that's greater than 5 millimeters and you don't see cardiac activity, that's abnormal. You should also see the yolk or the embryo by a mean sac diameter of about 16 millimeters, and you should have seen the yolk sac by a mean sac diameter of 8 millimeters. Here we've got a coned-in view here, but here you've got the embryo within the gestational sac here. It's also within the amnion, and here you can see the yolk sac here. Measurement of the crown rump length is accurate to 5 to 7 days menstrual age. It's important that you do not include the yolk sac within the measurement. And once the embryo is advanced enough in age that you can notice flexion and extension, the crown rump length measurement should not be used, since if the fetus is in a flex position, you'll underestimate the gestational age, and if the embryo is in an extended position, you may overestimate the age. Here we have two inaccurate crown rump length measurements. Here you've got one where the yolk sac was included, so this would overestimate. Here you've got one where the calipers are inappropriately placed, so this would underestimate the gestational age. It's important to remember, if you want to be able to do these measurements, you have to be in the right preset. If you're in the abdominal preset or cardiac preset or renal preset, you're not going to have the option when you hit the calculation package to do these mean sac diameter or crown rump length measurements. So this is another reason why you want to make sure that you use the correct preset. In terms of embryonic cardiac activity should definitely be seen by a crown rump length of 5 millimeters. If you've got an embryo with a crown rump length of 12 millimeters without cardiac activity, that's consistent with pregnancy failure. However, with technology being improved in recent years, we're able to now see cardiac activity much earlier. It's not uncommon to see the flicker of cardiac activity when the crown rump length is just a couple millimeters. When you've got a crown rump length less than 5 millimeters, it's also not uncommon to see a heart rate in the 80 to 90 range. We traditionally think of embryonic or fetal cardiac activity being between the 110 or 120 and 160 range. If the crown rump length is greater than 5 millimeters, the heart rate should be in that 110 to 120 to 160 range. However, if the crown rump length is less than 5 millimeters, it's not uncommon to see a heart rate in the 80 to 90 range. So here we've got a video clip of an embryo with obvious cardiac activity. This is a more advanced embryo here. Here we have a very early embryo. This is the yolk sac here, and here you've got an embryo that measured about 2.3 millimeters. And if you look on the clip here, you can see the flicker of the heartbeat here. And this measured in the 90s, which for a more advanced embryo would be bradycardia, but for an embryo that's 2.3 millimeters, this is not abnormal. But here, take a look at this closely. You can see the flicker here in this very, very tiny 2.3 millimeter embryo. If you document cardiac activity on a static image, you're going to use M mode. Here we've got a split screen image. This is the two-dimensional image. This is the M-mode image here. And you can see here is the yolk sac here. The gate is over the embryo. And here you can see the cardiac activity on the M mode here, and we're able to calculate that, and the heart rate is 99. So this is going to be the way you can prove whether you put an image on PACS or you put a thermal print on the chart that the embryo was either viable or non-viable at the time of your scan. Take a look at this patient. Do they have an intrauterine pregnancy here? On the sagittal image here, you can see urinary bladder, here's vaginal canal, and this looks like the uterus here. This appears to be low. As we sweep through, you can see that there's cardiac activity here. But remember, it's important to diagnose an intrauterine pregnancy if you've evaluated the uterus in two planes. You can't just diagnose an IUP off of a sagittal image. When we look at this patient in the transverse plane, you can see here's uterus over here. Here you've got myometrium. Here's a thickened endometrium here. This pregnancy is off to the side over here. This is a right tubal ectopic. So you have to be very careful. You can only diagnose an IUP after you've seen it in two planes and have confirmed that it's within the uterus. So when you're attempting to diagnose an IUP, you've got to make sure that there's at least 5 millimeters of myometrium surrounding the pregnancy. There are a lot of things that can cause an asymmetric location. You could have an implantation site that's eccentrically located. You could have a contraction causing that appearance. You could have a bicornuate uterus, or you could have an interstitial ectopic pregnancy. Here we have a transverse exam of the uterus in a patient with a bicornuate uterus, and we're scanning at about this level right here. You can see here's myometrium, and here's myometrium. So you've got the right horn and the left horn here. This is a patient with a bicornuate uterus. So in a patient with a bicornuate uterus, you can see why the pregnancy could have an asymmetric appearance to it in terms of its location. We have a patient with a bicornuate uterus, and you can see that as we sweep up towards the fundus, you can see you've got the left horn and the right horn over here. And within the left horn, you can see that there is a pregnancy. And measuring here, there is at least 5 millimeters of myometrium surrounding this. So this was an intrauterine pregnancy in the left horn of a patient with a bicornuate uterus. Let's look at this patient. Do they have an intrauterine pregnancy? On the sagittal image, you can see the sweep here. Here's the pregnancy here. Here's the uterus here. So is this something that's eccentrically located? Let's take a look at the transverse view. And you can see on this sweep, here you've got uterus, here's pregnancy, but is this the right horn and this the left horn of a patient with a bicornuate uterus? If you take a close look here, there's no myometrium that's bordering this pregnancy here. There's no border here at all. So that would go against this being an intrauterine pregnancy. This was a patient who had an ectopic pregnancy. So this can be a difficult call, especially when you first begin scanning. My recommendation is that if you're having to measure, is there a 5 millimeter myometrial border, it's better to have a comprehensive scan done by somebody with more experience, because you don't want to misdiagnose a interstitial ectopic as being an intrauterine pregnancy. Here's another patient here. Let's take a look at this transverse view on an endovaginal exam. So here we've got the uterus here, and here you've got this eccentrically located sac. There was a yolk sac in it, so it is a pregnancy. Now the question is, where is it located? And if you look, it is very eccentrically located. Here you don't have any myometrial mantle surrounding it, which is of concern that this is an ectopic pregnancy. If you take a look on the sagittal exam, you can see there's the sac, and you can see that it's actually in the mid-uterine range here. It's not in the area of the uterine fundus here. It's sitting right at this location right here. So this was not an intrauterine pregnancy. Again, there's no myometrial mantle surrounding it here. It's in a low position anterior. This is a patient who had a cesarean section scar ectopic pregnancy. Even if you don't recognize that that's what it is, the fact that this was so eccentrically located should have set off red flags for you. How about this patient? Do they have an intrauterine pregnancy? So here's the sagittal view right here. It's an anteverted uterus. Here's vaginal stripe right here. If you look at this area right here, at first you're going to want to say that's the bladder. But if you look right here, there's no wall, so that does not fit it being the bladder. This is actually the bladder here. It's being compressed. As we sweep through here, there's fluid in the cul-de-sac here. You can also see this area right here that's kind of gelatinous in appearance. It's kind of shimmering a little bit. This is clotted blood. This is free fluid here in the anterior cul-de-sac. On this limited sweep in the sagittal plane, I don't see a definitive intrauterine pregnancy. As I go transverse, here you've got a sac with a yolk sac in it. But again, this is very eccentrically located to the right side of the uterus. This is a transabdominal transverse image here, and I don't see a myometrial mantle surrounding this. And again, there's no myometrial mantle here surrounding this area here. So this is a patient who had a ruptured right interstitial ectopic pregnancy. Here we have a patient who has a dichorionic diamnionic pregnancy. There's two discrete sacs here. So when you're dealing with someone who's got a multiple pregnancy, you want to diagnose, if at all possible, the chorionicity and the amnionicity, because it's going to be easiest to determine during the first trimester scan, and this has significance to the obstetrician caring for the patient. In terms of diagnosing a twin pregnancy, you only want to document a twin pregnancy if you see a yolk sac or an embryo. It's the same as diagnosing a singleton pregnancy. In terms of nomenclature, the embryo that's going to be closest to the cervix is going to be pregnancy A. Here we have a patient with a dichorionic diamnionic pregnancy. You can see here is one amnion, and you can see here's the second amnion, and they're contained within two different chorionic sacs here. And here's a transverse view. Here's one pregnancy, and here's the second pregnancy. So this is a dichorionic diamnionic twin pregnancy. Let's now look at the abnormal intrauterine pregnancy. Subchorionic hemorrhages are commonly seen. They are abruptions of the placental margin causing elevation of the chorionic membrane. The size of the hemorrhage is going to be the most important predictor for pregnancy failure. Here you can see an echogenic subchorionic hemorrhage surrounding this pregnancy here. It's very small. Chorionic hemorrhages can be either anechoic or echogenic, and they usually will have a falciform shape due to the fact that it conforms to the shape of the uterus. So here you've got a subchorionic hemorrhage that extends approximately 50% around the gestational sac. As opposed to using terms like blighted ovum or anembryonic pregnancy, I prefer using terms such as definitive pregnancy failure or possible pregnancy failure, definitive intrauterine pregnancy, possible intrauterine pregnancy, definitive ectopic, possible ectopic. To diagnose a definitive pregnancy failure, you're going to need to see an embryo greater than 5 millimeters without cardiac activity. To have a possible pregnancy failure, you need to have an irregular sac that does not have a yolk sac by 8 millimeters mean sac diameter, or no embryo at greater than 16 millimeters mean sac diameter. Here is evidence of definitive pregnancy failure. You've got an embryo here that's greater than 5 millimeters, and you have no fetal cardiac activity. Now, the criteria that I just gave you on the last slide, you can find those in any textbook on radiology, ultrasound, obstetrics. But that being said, there are some that are concerned that this criteria is too strict and is going to lead to termination of viable early intrauterine pregnancies. And there was a review article that discussed this in the New England Journal of Medicine back in 2013, and I would highly recommend that you read this article. The authors were concerned that the criteria that's currently out there is too strict and is going to lead to termination of potentially early pregnancies through the use of methotrexate. So what they were recommending is broadening out the criteria for definitive as well as suspicious criteria for the diagnosis of a non-viable pregnancy. Here's what the authors of this New England Journal review article are recommending for definitive diagnosis of pregnancy failure, as opposed to the current recommendations of crown rump length greater than or equal to 5 millimeters and no heartbeat. They're recommending a crown rump length of greater than or equal to 7 millimeters and no heartbeat. A mean sac diameter of greater than or equal to 25 millimeters and no embryo. The current recommendation is a mean sac diameter of greater than or equal to 16 millimeters and no embryo. The absence of embryo with heartbeat greater than 2 weeks after a scan that showed a gestational sac without a yolk sac. And lastly, absence of an embryo with heartbeat greater than 11 days after a scan that showed a gestational sac with a yolk sac. The authors are recommending that the suspicious findings for pregnancy failure be the following: crown rump length less than 7 millimeters and no heartbeat, mean sac diameter of 16 to 24 millimeters and no embryo, absence of embryo with heartbeat from 7 to 13 days after a scan that showed a gestational sac without a yolk sac, the absence of an embryo with heartbeat 7 to 10 days after a scan that showed a gestational sac with a yolk sac, absence of embryo greater than 6 weeks after last menstrual period, enlarged yolk sac greater than 7 millimeters, empty amnion, meaning an amnion that's seen adjacent to a yolk sac without embryo, and lastly, a small gestational sac in relation to the size of the embryo. So the question is, which criteria do you accept? You have to remember, this is a balancing act, that if the criteria is overly strict, that there is the risk that when somebody meets the criteria for pregnancy failure, that it may indeed be an early intrauterine pregnancy that's viable. On the other hand, if we accept the criteria that the authors of the New England Journal article are recommending, there's a higher risk here that we're going to miss potential pathology or delay the diagnosis of potential pathology such as an ectopic pregnancy. So I think it's good to keep in mind that, as with any criteria, you have to have some latitude, because obviously the goal is to not terminate an early intrauterine pregnancy, but to also not delay the diagnosis of an ectopic pregnancy. So keep in mind that that the current criteria is not written in stone, that if you don't see a cardiac activity with a crown rump length at 5 millimeters, that there still is the potential that this could go on to be a normal intrauterine pregnancy. The other thing to keep in mind, a lot of these measurements boil down to how accurate your caliper placement is. And I think that's a separate discussion in and of itself. But I think just keep that in mind. This review article does bring up good points about the safety and accuracy of the current criteria, and it is good food for thought. But I think you just have to keep in mind that it is that balancing act, and you have to look at that with each and every patient that you're treating. Be careful when using ultrasound to diagnose a completed miscarriage. The diagnosis cannot be made with certainty with ultrasound. In a patient with a completed miscarriage, you're going to have a normal pelvic ultrasound. There'll be no definitive placental or fetal tissue seen. If you've got a patient who came in, you've got witnessed fetal parts passed, that helps in making the diagnosis easier when you couple this with your physical exam. However, a lot of patients will tell you that they passed the tissue at home when in reality they just passed clots and they've got an occult ectopic. So you've got to be very careful about using ultrasound to confirm that someone's had a completed miscarriage. The diagnosis of an incomplete miscarriage should be made in conjunction with your physical exam findings. Ultrasound findings include obvious presence of placental or fetal tissue, which makes it a no-brainer. Non-specific finding would be endometrial thickness greater than 10 millimeters. If you rely on this finding alone, you would take a lot of women to the operating room for D&C unnecessarily. If you've got what appears to be a heterogeneous fluid collection within the endometrium, put color Doppler on it. If you can verify the presence of feeder vessels like you see here, then this helps confirm that there's retained placental parts, and you can make then the diagnosis of an incomplete miscarriage. With molar pregnancy, most of the findings that have been described are ones that you're going to find in late first trimester, early second trimester, where you're going to have an enlarged uterus and abnormally high quant, and sonographically, you're going to have the classic cluster of grape appearance. You're going to have complex mass within the endometrial cavity with multiple small cystic spaces. In early first trimester, the findings of a molar pregnancy could look very similar to the findings of pregnancy failure. So you would need to couple this with the quant, but you have to be very careful. The classic findings described in the literature pertain to late first trimester, early second trimester findings. Here's a patient who is about 6.5 weeks pregnant. You can see within the endometrium here, there's this multiple cystic area. There are multiple cystic areas. And on the transverse view, you can see the same thing here. There's no definitive IUP. But you can see that the endometrium is heterogeneous and there's multiple cystic areas. If the quant on this patient was 485, this could go along with hydropic degeneration and pregnancy failure. However, this patient had a quant of approximately 65,000. She was followed up and the quant kept rising, and she was taken to the OR where the diagnosis of a molar pregnancy was confirmed. Let's take a look now at ectopic pregnancy. Definitive diagnosis of an ectopic pregnancy requires that you visualize a yolk sac or embryo outside of the uterus. The most common type of ectopic pregnancy is going to be a tubal pregnancy that's in the ampullary region of the tube. Since this introductory lecture is going to focus more on intrauterine findings as well as findings of the cul-de-sac, are there any intrauterine findings that could help you in leaning towards a diagnosis of an ectopic? Well, the endometrial findings associated with an ectopic pregnancy are variable. You'll get a pseudosac in about 10 to 20% of cases. Endometrial thickness can be variable, so this can't be used to rule in or rule out an ectopic pregnancy. However, a trilaminar appearance of the endometrium is highly specific for the diagnosis of an ectopic, but the sensitivity is low. So if you see it, this should point you towards the diagnosis of an ectopic pregnancy. Here's a patient with a pseudosac. You can see here's the road, the endometrial stripe, and this is literally in the road here at the end of the cul-de-sac. And this is just a decidual cast from the hormonal reaction from the ectopic pregnancy. So this is going to be located centrally in the endometrial cavity. And in theory, there should only be one layer present. However, there have been cases described where a double decidual sac appearance was present. Here we have two patients, both of whom had ruptured ectopics. The patient on the left here has an anteverted uterus on this sagittal exam. There's no intrauterine pregnancy seen, and you've got complex fluid in the anterior and posterior cul-de-sacs. And if you look, the endometrial thickness is relatively thin. Here we've got a patient who has a ruptured ectopic. Her uterus was retroverted here, but they have a nice thick endometrium. And here you can see the ectopic pregnancy here, and there's some free fluid here. So here's one with a thick endometrium, here's one with a thin endometrium. Both had a ruptured ectopic. So the endometrial thickness cannot be used to make or exclude the diagnosis of an ectopic pregnancy. Here's the trilaminar appearance where you have three lines. You have 1, 2, 3. This is essentially the appearance that you would expect to see in the follicular phase of the menstrual cycle, not what you would expect to see in the luteal phase or in early pregnancy. So if you see this, it's considered to be specific for the diagnosis of ectopic pregnancy. Here's another patient who had an ectopic pregnancy. Here you can see 1, 2, 3 lines. This is a trilaminar appearance here, and this was a patient with an ectopic pregnancy. Now with free fluid, you can have small amounts of simple or anechoic fluid in the cul-de-sac, and that can be normal. And it's important to remember, hemorrhage can either be anechoic or echogenic. However, if you see echogenic fluid, regardless of the amount, it's hemoperitoneum until proven otherwise. Here's a sagittal view here of an anteverted uterus. There's no IUP seen. You've got some fluid in the posterior cul-de-sac here, but it appears anechoic. However, if you look here in the anterior cul-de-sac, you see complex appearing fluid. This was a patient who had a ruptured ectopic. When you have a patient that you're suspicious has a ruptured ectopic, I would always advocate performing a perihepatic window, because if you see fluid in the perihepatic space, this is clearly abnormal. It will never be physiologic. And several studies have shown that patients who have ruptured ectopics and have fluid in Morrison's pouch, there's a high need for surgical intervention on these patients. Here we have a patient with complex fluid in the cul-de-sac. If you look, there's fluid going along the back wall of the uterus here. It's an anteverted uterus, a sagittal view, but you can see there's echoes within here. And note the nice triangular corners here that you would expect with free fluid in the peritoneal cavity. But this patient has echoes. Even if this was a very small amount of fluid, the fact that it has echoes means there's hemoperitoneum until proven otherwise. In a non-pregnant patient who is febrile, remember, ultrasound cannot differentiate between purulent debris and hemorrhage. So a patient with a temp of 102, 103 who comes in with symptoms of a TOA, this could be pus. So just keep that in mind. Here's a patient that has a very large amount of hemoperitoneum, and it's all complex. If you look here you've got the uterus. It's anteverted here. You can see that there's triangular corners here as the fluid is interacting with the bowel the whole way around the uterus. And up here into the anterior cul-de-sac, there's a very large amount of complex fluid here. There's no intrauterine pregnancy seen. The findings of no intrauterine pregnancy and the presence of a large amount of complex free fluid is consistent with a ruptured ectopic in this pregnant patient. It could also be possible that this patient could have hemorrhage due to rupture of a corpus luteum cyst, but regardless, this patient has a large volume of hemoperitoneum and is going to require surgical intervention. Here's a patient that had a ruptured ectopic and had a large volume of clotted hemoperitoneum. When you look, here's the sagittal transabdominal view. The first thing you have to do is define the outline of the uterus. And here you can see it coming along here, coming over to here, and over to here. So you can see these complex areas surrounding it. Here you've got free fluid here. There's no wall around it, so that's not the bladder. This is the bladder. This is complex fluid here. There's no intrauterine pregnancy seen. So in this pregnant patient, this is consistent with ruptured ectopic until proven otherwise. Here's the transverse view here. You can see the uterus right here. Here's the ectopic pregnancy. But even if you couldn't recognize the ectopic pregnancy, the fact that you've got no intrauterine pregnancy and a large volume of hemoperitoneum warrants emergent obstetrical consultation and operative intervention. So does this patient have hemoperitoneum? This is one where the initial clinician performing the exam missed the presence of hemoperitoneum. And if you take a look at this exam closely, you have to ask yourself, where is the uterus? And the uterine outline is right in here. So it's an anteverted uterus. And this is all complex fluid in the cul-de-sac wrapping around into the anterior cul-de-sac. There's no intrauterine pregnancy seen. So this is a patient who has a ruptured ectopic until proven otherwise. The fact that there's no anechoic free fluid made it easy for the clinician to miss this. So you've got to be aware of the presence of echogenic free fluid. And don't forget to do the perihepatic window if you're suspicious for ruptured ectopic. That's going to be an intercostal oblique window with the indicator directed towards the patient's head, somewhere between the 8th and 11th intercostal spaces at about the mid-axillary line. That'll give you this image: lateral, medial, head, foot. You've got liver, you've got kidney, you've got perinephric fat here, and you're going to look for free fluid here in the peritoneal space. Here's another image on a patient. No perinephric fat is seen here, so you're going to look for fluid coming along the border of the liver here into Morison's pouch. And here's a patient with a positive right upper quadrant window. You can see here's liver, here's kidney, here's perinephric fat. So this is true capsule of the kidney. This is Gerota's fascia. This is going to be Glisson's capsule surrounding the liver. And here you've got hemoperitoneum surrounding the liver here and interacting with bowel here. So this was a positive right upper quadrant window. Let's look at some clinical pearls on how to best use this focus study. If you see an intrauterine pregnancy in a stable patient with a benign exam, no free fluid, and they don't have any significant heterotopic risk beyond the general population, and you're not concerned about another etiology for their abdominal pain, these people can be discharged home if stable with follow-up. What if you see an intrauterine pregnancy, no free fluid, but this is a patient from the assisted reproduction clinic? These patients have a 1 in 150% chance of having a heterotopic pregnancy, so these patients need comprehensive sonographic evaluation for heterotopic pregnancy and close follow-up. What if you don't see an intrauterine pregnancy and free fluid is seen? Particularly if you see free fluid in Morison's pouch, these people need emergent obstetrical consultation. They should be considered to be a ruptured ectopic pregnancy with hemoperitoneum until proven otherwise. What if you have a patient who has no intrauterine pregnancy, no free fluid seen, and a quant less than 1,000? Remember, since all we've done with this study is look at intrauterine and cul-de-sac findings, we have not addressed the adnexa, so these people need comprehensive scans since their differential includes early IUP, occult ectopic, or pregnancy failure. So remember, focus at this point on intrauterine findings, both transabdominally and transvaginally, as well as cul-de-sac findings. In future modules, we're going to build on how to evaluate the anexa more successfully. This now concludes the first trimester OB focused ultrasound lecture.